Thank you very much, Matthias, for presenting our data. Now I would like to continue on when to think about detrusor underactivity when in female patients. What's happening here? Okay. Thank you. This is data of partly on behalf of the same research group, and these are my sorry.
The lights.
Oh, the lights. Okay, thank you. Sorry. Sorry, I don't have the official slide, but these are my conflicts of interest. When we have a patient, a young lady of 24 years, presents at my outpatient clinic, performs clean intermittent catheterization, cannot void since a urinary retention due to a urinary tract infection. Evaluation was done in another hospital. An acontractile bladder on conventional urodynamics was shown. And the patient voided only twice a day since childhood. And this you sometimes see patients can train their bladder to hold quite a lot of urine. Voided far less than her friends. She could keep up, never participated in collective bathroom visits like many young girls have. She's ambitious, voiding was a waste of time. Her retention was 1.5 liters at a urinary tract infection. And there was some bad management afterwards. She didn't get a catheter and it was a lot of delay. And then she turned out to, she had to do CIC. And then she presented at our clinic, and now the patient's question is, what are my options? This is a rare case, of course, but maybe it occurs more often and we don't see them because those young individuals, they have a lot of compensatory capacity. Now, female patients with voiding difficulty, what is the problem? There is some data that says that there's only 4% obstruction in females. So this would mean that the flow rate would represent the detrusor action, so the contractility of the detrusor. I doubt whether this is true. And this obstruction can be due to primary bladder neck obstruction, dysfunctional voiding, or urethral or meatal stricture. And the females, another problem is that the females may not have any detrusor pressure increase at all. And because they don't show sometimes any urethral resistance. But they have a contraction, of course, they empty their bladder. So there has to be a contraction of the bladder there. It only doesn't show that there's no pressure increase at the same time. The flow is not necessarily indicative of the contractile capacity. And how do we know that the bladder is maximally stimulated during voiding? We don't know. Maybe there's a reserve capacity of the bladder. And that's why I don't think it's important to measure a reserve capacity. And so the actual flow is not really representing the ability to contract of the bladder. And then there's, to make it even more complicated, there's a combination of over and underactive bladder symptoms. That was already pointed out yesterday in the talk of Paul Abrams in the male LUTS session. And this was also shown in his database. There have been not many studies in female patients. We did a couple of preliminary studies in our database of pelvic care patients, which consists of both male and female patients. We had 6,000 patients in total in our database. We did an evaluation on a general questionnaire, and this is presented in abstract 7 on this meeting by Heidi Moosdorf, and she made a start in evaluation of this female database. And then we did a small pilot study, and this was on this was comparing these questionnaires with urodynamic data we had in only 259 patients of these 6,000. And the goal was to evaluate the discriminative ability of this combination of questions. Well, in this study on the general pelvic floor complaints, we had 2,660 women with LUTS. 59% of them had self-reported voiding complaints, which is a lot. It's really much more than we expected. And there's a significant association with other general pelvic floor complaints, like incontinence, constipation, and fecal incontinence, but not with pelvic organ prolapse, something you would expect, actually. And there's also a significant correlation with specific voiding symptoms, like feeling of incomplete emptying, weak or intermittent stream and straining. This study, of course, has to continue, and thus this advocates for a multidisciplinary approach, because we see so many other complaints being there at the same time. And we looked at a couple of specific voiding questions, like there are here: feeling of incomplete bladder emptying, hesitancy, weak stream, abdominal pressure during voiding. And this is just to start to see what complaints would be there at an underactive bladder. And urinary tract infections during the last 6 months. And as a pilot, we took of this database the 10 patients which scored the highest and the lowest on these set of questionnaires. It was only a very preliminary pilot, I must say. But we saw an enormous difference in urodynamic data in these two groups of 10 patients. This is only a start. We needed some money to continue with this research. Mm-hmm. But you see the difference in bladder capacity, and especially the voiding effectiveness was extremely different in these two groups of patients. We did already also do a preliminary evaluation of Wmax. This was only possible in 182 of them, but then you saw some significant association of Wmax with feeling of incomplete bladder emptying and intermittency on bladder emptying. And this is quite striking, because this is very similar to what was published in the European Urology paper of Andrew Gommert, although this is a very small group of patients. But can we differentiate between different causes of voiding dysfunction by symptoms alone? And this was already addressed by Chris Chappell at first. It was addressed by Matthias. We have to differentiate between these causes of voiding dysfunction also in women. Maybe it's in the publication of European Urology of Gommert, and there's also a clear no of some recent literature, but this is all not based on sufficient data. And the major problem is we need sufficient to diagnose the condition sufficiently. And that is the problem. We need some parameters, urodynamic parameters, to define that. Rather, we would have non-invasive parameters, but we have to look for them. Interestingly, in this current opinion article, it says, however, all of these measures may be more relevant to research than clinical practice, where numbers matter less than overall clinical impression. In many cases where the clinical diagnosis remains unclear, urodynamics can assist in distinguishing UAB, but we need some to set some threshold values for the urodynamics. And this is especially difficult in women. What are possible precipitating factors? It can be aging, but my case I presented at first, it militates against this idea. This is a very young girl, woman. Diabetes, neurogenic disorders, hypertension, UTIs, obstruction, psychogenic, sociogenic constitution, training your bladder because you're so busy. What's happening in aging? This is mainly, I think, in the male population that obstruction increases during aging, but then maybe also in the female when they get more pelvic organ prolapse, or when they needed stress incontinence, anti-stress incontinence surgery. But definitely contractility decreases with age. And if you have some extra precipitating factors like dysfunctional voiding, like urinary retention, it might very well be that your lifeline of contractility is going to cross the urethral resistance line. And then you run into problems right here. What do we need in the future? As said, we need adequate diagnostics to identify the condition. We also need some longitudinal studies to validate our ideas. Then an identification of the precipitating factors and the development of a kind of stress test in women. Because if a woman has no obstruction at all, it's impossible to measure the detrusor contractility. So the idea is that also during life there is a kind of contractile reserve of your contractility, and that the bladder can compensate if the obstruction increases. But it would be interesting to measure this, but also a subphysical relaxation capacity. If there is a dysfunctional aspect in your obstruction, then it might be possible to decrease that to decrease this contraction. This might be done by just pelvic physiotherapy. And then there's this stress test I told you about. What are now the options for my patients? First, an ambulatory urodynamic test was done. And this test was already done, and we saw actually some contraction in her. She was not acontractile at all. And we saw in an evaluation we did already a couple of years ago that 80% of the people that is sent to us with acontractile bladder on conventional urodynamics actually has a contractile bladder on ambulatory urodynamics. Of course, the ambulatory urodynamics needs extra validation, but this is a very interesting aspect, and it was already published in 2010 in this publication. And the recent publication already shown by Chris Chappell also looks at the effect of neuromodulation and ambulatory urodynamics. So what we can do, sacral neuromodulation, targeted physiotherapy, latissimus dorsi myoplasty, also already addressed by Professor Chappell, or continue clean intermittent catheterization. As a matter of fact, this patient responds favorably to sacral neuromodulation, so we're really happy that we could help her. But how can we prevent these problems to develop in our children? I think there's a very interesting aspect we have to address as well, to stimulate frequent toileting, to allow children to go to clean bathrooms at school. But this is just a spin-off of my thinking. Then I would like to thank my team in Maastricht to allow me to be here and to take care of the clinical situation at the moment. So then I would like to close this talk and start a discussion with the three of us. Thank you very much.
Shall I lead the discussion, because you two guys have presented acute research, so can we have the lights up, please?
Can you put it on black, please?
So, the excellent work with the Hanover normogram with Maastricht clearly follows on from the existing urodynamic principles and shows a nice graphic way of demonstrating what's going on. The female that you mentioned, if you go back to the publication from Urological Clinics in North America in 1979, this described the concept of the camel bladder. In other words, a group of women who have voiding in frequency. And we all see patients clinically, ladies who fracture their hips and go into retention, or are constipated. So the question is whether it's a behavioral abnormality or whether it's an intrinsic constitutional abnormality with a relative dysfunction of the neuromotor axis. That's what your work will demonstrate. Now, there's no doubt about the integrity of your work, and what I'm going to say now is not a criticism, and you know what I'm going to say. When you get on to bladder wall thickness, you have a whole gynecological group of people who think that a thick bladder wall is detrusor overactivity. Bladder wall thickness will depend upon the volume of the bladder at which it's measured, so could you comment on that? Secondly, you don't often see patients with high pressure chronic retention with a thick bladder wall. It's usually a big floppy bag. So we'd all agree, if you've got a thin wall, it fits with underactivity. So is it a chicken and egg situation, or is it a consequence? The next question is, if you look at neuropaths who often have detrusor sphincter dysenergia, but of course intrinsic to that high intrinsic pressures. And we also look, and I know your data shows you've allowed for this, but with men, 2/3 of men with bladder outlet obstruction have detrusor overactivity from most of the urodynamic studies. And 98% or 99% of the bladder's time is spent storing, not contracting. So how should one equate the difference between men and women in the same species with bladder wall thickness? And the next problem is using it, and the reason I apologize for not putting it in my talk was because the shrink study, which looked at bladder wall thickness, showed a very high intra and inter-observer error when you're dealing with 1.8 millimeters versus 3.2 millimeters with different people. So just a couple of questions, if you two could lead off on those.
I suggest you start.
These are good questions. When you measure the detrusor wall or bladder wall thickness with ultrasound, obviously you need an ultrasound machine which is available in all German urology offices. So we have it. It's a transscrotal probe. You have to use a high frequency ultrasound scanner, so it should be bigger than, or it has a frequency greater than 7.5 megahertz. With the depth of penetration of a 7.5 megahertz, it's becoming clear that you can only judge the anterior bladder wall. The anterior bladder wall, the entire bladder walls are dependent on bladder filling. The thickness is dependent on bladder filling. The more volume, the thinner it becomes, right? So you have to define your methodology. Are you measuring bladder wall thickness? Are you measuring detrusor wall thickness? Detrusor is only the detrusor, and bladder wall thickness is the adventitia and the mucosa additionally. So you have to define what are you measuring, at what bladder capacity are you measuring. And so one technique has to stay with one technique, and you cannot compare both techniques, right? Good. When you are now comparing these patients with detrusor overactivity with obstruction, detrusor obstruction without detrusor overactivity. So Chris was mentioning when you have detrusor overactivity, you have it many times per day, so the time being is in favor of detrusor overactivity in the storage phase, and you void only a couple of times. But this is actually not the truth. Unfortunately, I cannot prove you with a publication, but I analyzed with Andrea Tubaro and with my personal data that detrusor overactivity, at least with our techniques, bladder wall thickness measurement with 150 milliliters or detrusor wall thickness measurement with more than 250 milliliters, that detrusor overactivity does not play a role with detrusor wall thickness measurement. We unfortunately are very busy people, and we have not published it. I'm regretting every time I see you and we have this discussion, because I have to publish this. And you can compare this like a marathon runner and a bodybuilder. A marathon runner runs long distances, but he is a tiny person. He is slim. A person who lifts great amounts of weight, bodybuilder, he develops big amounts of muscles, and that seems to be the same principle in the bladder. So what we think, the bladder wall thickness measurement is dependent on obstruction only and not on detrusor overactivity. And there was the issue with the inter-observer variability and the shrink study. I was one of the evaluators, so I had all these images for the shrink study. The shrink study was a urodynamic study where they had to have detrusor overactivity. Then they received a detrusor wall thickness or bladder wall thickness measurement, and then they received placebo, solifenacin 5 or 10 milligram, and after 12 weeks they were measuring again the bladder wall thickness. The problem with this technique is when you are investigator in your home office, you have a dynamic image. You can turn, you can twist, you can press a little bit, and you can make the most optimal image that you want to have. In this study, we had about 30–40% really poor images. This was just a snapshot of the situation, and sometimes it was extremely difficult to see the borders of the bladder. Sometimes it was not even possible to see anything. According to this judgment, we were not able to show significant effect with solifenacin. However, I think this was more a methodological problem than it was really the reality. So we have many problems in defining, but what we were advocating with our measurement with the detrusor wall thickness in combination with bladder capacity, this is a screening tool for, let's see, severe patients. These patients have severe detrusor underactivity. This can be a screening tool in your office for men who may want to go a TRP or another operation. And when you see big bladder capacity and a thin bladder wall, you may want to do a urinary investigation to quantify all these measurements. However, when you see a patient with a thick bladder wall, and maybe not a huge bladder capacity, but such a thick bladder wall, then it's highly likely that he has bladder outlet obstruction. You can use it as a screening test. It's not the same value than a urodynamic investigation, I know that, but it's a screening test. We need something to distinguish, roughly distinguish, this is a candidate for TRP, this is not a candidate. This is a man who will most likely go to retention with an antimuscarinic, he does not. So we need these kind of tests to be practical. And this is one of the tests, and we were publishing this because this was the first publication where we described that this is possible with non-invasive tests. Otherwise, it's only urodynamics.
Well, can I just come back on that? You've answered the question extremely well, but the shrink study was using it as a biomarker for detrusor overactivity.
Yes.
Which you didn't mention. The
Yes.
second thing is that the bladder is not made out of striated muscle, in my experience. And bodybuilders are doing striated muscle.
That's true, but it's done automatically with a smooth muscle cells with a specific measurement technique. Transvaginal probe, empty bladder. It seems to be something you can diagnose detrusor overactivity. When you do the same thing in women with a suprapubically placed ultrasound, you cannot see detrusor overactivity anymore. These are the cool studies. Yeah? So it is a method. It's a method difference, I think.
The reason I raise this is because it's good to have this debate at the ICS.
Right.
Because there is this disparity in the literature, which is important because, you know, there's a whole group of urogynecologists who believe it does show overactivity.
Right. What we actually did, we want to have a good classification what is detrusor underactivity. Because this is necessary when we do trials, when we do clinical assessment. We want to have good parameters to define our patient population. And we thought in our research group it's a good way to go from the known, that's urodynamics, to the unknown. So we were approaching what is known.
I would just suggest, because otherwise we get a very low grade on interactivity.
No, you need to get comments from the audience. No, just raising that because there's a disparity in the literature.
It's a very good point.
One can be very vehement about one's beliefs, but one has to acknowledge the fact others have a, different knowledge and evidence out there.
Yeah.
Very important. Please take the microphone. Walk to the microphone, please. Thank you. Sorry to ask you to do that, it's just easier. If you've got a loud voice like me.
Thank you very much for your presentation. This is very interesting. My name is Marianne Harvey from Kingston, Canada. I really enjoyed listening and hearing about the Maastricht Hanover. I didn't pronounce it right, but you meant. Do you have any data of its use and applicability for women?
No.
No, we don't. Unfortunately, we don't yet.
Is there any plan on it?
Yeah, one of the problems is that women are not as obstructed. You're in a completely different. You measure in a completely different area, and it would be really interesting. And of course, we are going to try this, but I think first we need another measurement method in women to make it possible.
Because contractility is hard to assess
Yes,
because of the
that's
extra
right.
contraction.
Yeah.
Thank you.
And then you have to think on when is this necessary. Well, I think of course when you are going to you plan to perform stress incontinence surgery and you think of an underactive bladder or something like that, or if we might have a more non-invasive tool to do it community-based and to see why people have urinary tract infections, whether there's some possibility. But then it's only useful if you have a treatment for it. So I'd like to give the floor to the other questions. Thanks a lot.
Thank you.
My name is Jan Krut, coming from Czech Republic, Ostrava. And I would like to ask you what do you think about the role of the another ultrasound parameter, I mean intravesical prostatic protrusion. If does it play a role in the distinguishing between the underactivity and obstruction?
Yeah, you're now mentioning a tool where you measure the prostate or the prostate medium lobe, most probably from the bladder base until the tip of the prostate. And when you have bladders filled between 150 and 300 milliliters in the longitudinal section, you can measure the distance. It's called intravesical prostatic protrusion for you, a gynecologist. And there was one publication by Chia in 2008-7 that he described this is a parameter for bladder outlet obstruction. Has nothing to do with the detrusor underactivity. But what he mentioned is not bladder outlet, he was talking about benign prostatic obstruction. And this is a certain type of obstruction. But imagine now you have a patient with a urethral stricture. He will not have an IPP, but he still has obstruction, which you can see with detrusor or bladder wall thickness measurement. Again, this is only obstruction. You can confirm or you can reject obstruction, but it's no information about detrusor contractility.
I think it's very important to realize there's a body of work that you mentioned from KT Fu in Singapore, who spent most of his career publishing on this. And there's a lot of good evidence, you're quite right, that the different categories of intraprostatic protrusion had a significant impact on voiding function and potentially on underlying detrusor function. So you're quite right, and that he's got very compelling data, prospective data, which shows the importance of that. The second thing is, if you actually look at some of these newer techniques, such as the Urolift, in the study we participate, like my colleagues here, I'm sure, so many patients were excluded because of intraprostatic protrusion. So one has to analyze data very carefully when you see these presentations, because it does depend on the anatomical positioning of the median lobe. So it's a very good point.
Hi, I'm Mary Fitzgerald from Ireland, Europe. I have a question. As this field is developing for women and clinical use in women, I just wonder have there been studies in ambulatory, asymptomatic, community-dwelling women, so normal controls, and retest of controls, just as we developed urodynamics for detrusor overactivity, turns out present and normal, comes and goes, and how much of this comes and goes in normal women and may turn out not to be important?
Right, do you have a good answer? And
I'm afraid
there's no study.
I'm afraid there's a big lack in literature in here, and it becomes really interesting now. I agree.
You have funding and... Maybe you could
Well,
control.
No, we have to correct you. We had funding. We had funding.
2012, it's completely finished.
But after
It's
crowdfunding.
below zero. It's below zero now.
No, but to answer your question, I'm sufficiently old, being around too long probably, that many years ago from Maastricht, there was a lot of work that came out on ambulatory urodynamics.
That's mainly on males.
On males, but we've done some work on females, published in the BMJ, where we compared prospectively 100 women undergoing urodynamics and conventional urodynamics and ambulatory. Steve Radley, gynecologist, published that.
But
And
would you have diagnosed these conditions in any of those women looking back?
We found it much more sensitive than conventional urodynamics.
So asymptomatic ambulatory women, did any of them, would you now diagnose them with?
You probably would, yes.
But somebody should look, I think.
Go back to that, I agree. That's
Just
where
The problem is that it's very difficult to analyze the voiding phase during ambulatory
But
urodynamics.
I don't mind
Because-
if it's in the
yeah,
lab,
yeah,
it doesn't have to
sure.
be ambulatory.
the trouble with ambulatory urodynamics, as you quite rightly say, is you can't call it overactivity. It's involuntary detrusor contractions. And 90% or no, 75% of normal men and women have involuntary detrusor contractions on ambulatory urodynamics. Asymptomatic ones. So it's still work in progress, but it's very valuable work that you're doing. Get rid of me.
Are there any other questions? Well, otherwise I think we're right on time. And I'd like to close this session. Thank the speakers very much for the beautiful presentations. Thank you very much for the discussion. And this is work in progress. And I hope we can have this workshop many times with new data. Thanks a lot.